Good morning. Convening this informational briefing on Wednesday, March 6, 2024. It's 10 a.m. We are in conference room 329 at the Hawaii State Capitol. This is the Committee on Health and Homelessness. I want to thank all of our presenters here. As noticed, this is an informational briefing on our Prepaid Healthcare Act, its requirements, and its regulatory framework that has been in place for nearly 50 years, ensuring access to healthcare for Hawaii's residents and families. One of the impetuses for this hearing is a number of bills that we've been hearing throughout this legislative session. It is the fourth recess day in a very busy legislative session. Some of the bills, again, as I mentioned, are related to mandatory health benefits for reproductive health care services, for screenings, for fertility benefits. And so there's a lot that's kind of been moving this session and in recent years around insurance that might have impact on the Hawaii's Prepaid Healthcare Act. So we wanted to pull this very esteemed group of practitioners, people who work closely with our health insurance markets to kind of shed some light on the Prepaid Healthcare Act here in Hawaii, how it interacts with federal laws, in particular with the Employee Retirement Income Security Act, as well as the more recent Patient Protection and Affordable Care Act, also known as the ACA. So with that, I'm going to start off with Ms. Joanne Wed Mar, who is the Administrator of the Disability Compensation Division, to give us an overview of the Prepaid Healthcare Act. So I'll turn it over to you.
Good morning, Chair Bellotti, and thank you for inviting us to this very important briefing. Hawaii's workforce, and I'm on slide 2, Hawaii's workforce has enjoyed progressive health coverage policies, as you said, since 1974, 50 years when Hawaii's prepaid health care law went into effect. The main benefits of the prepaid health care law are that our employers are mandated to provide health care coverage for Hawaii's employees that work 20 hours or more a week for 4 consecutive weeks and earn a minimum monthly wage of 86.67 times the minimum wage. It also provides low health care deductibles. It caps out-of-pocket expenses. It provides for cost sharing and limits employee premium contributions to 1.5% of the employee's wages. Next slide, please. Statutorily, the department is required to review all health care plans for employers before they can offer this coverage. The Prepaid Healthcare Advisory Council is an advisory council to the director. They review plans in conformance with the prepaid healthcare law. The Healthcare Advisory Council advises the director whether the benefits that will be offered in these plans will comply with statutory requirements. These plans are either called a 7A or a 7B plan. A 7A plan is one that is equal to or better than the prevalent plan, so the plans that are most subscribed here in Hawaii, or a 7B plan, which has more limited benefits, but it requires a greater contributions for dependent coverage. And the plans must be approved before employers can offer the coverage or implement any plan changes. Next slide, please. So our deductibles that they review are currently the prevalent plan is 0 for preferred provider organizations, and it's $100 for the HMOs, the Health Maintenance Organization. We have under prepaid with the Prepaid Advisory Council established a maximum of $350 for deductibles. And then they look at the out-of-pocket maximums. So current prevalent plan out-of-pocket maximums for HMSA and Kaiser is $2,500 for individuals and $7,500 for the family. And then we also look at family out-of-pocket maximums. We cap it at a 2 to 3 times the individual out-of-pocket maximum.
Ms. Wed Mar, if I can,
Yes.
just because so the questions will flow, if I could interrupt with questions?
Yes.
And these simple questions, because really we want to understand the mechanics of how prepaid healthcare works in our state. This is as much for me and my colleagues as well as for the public. So going back to the previous slide, for the council, when does this approval process for plans affecting the entire marketplace essentially happen?
So the plans are reviewed on an annual basis. And so the plans come into the department, and we look at the prevalent plan for HMSA and Kaiser, and then all other plans from the other providers are compared to the prevalent plans. And so that's done on an annual basis. And every quarter, at least on a quarter basis, the advisory council will meet to review these plans and recommend approval or non-approval, which we'd look at making changes for those plans so that the director would be able to approve it if it is in compliance with the prepaid law.
So this is basically like the very first step for any plan, any new plan that's developed, to get a review by the state to see if it's in compliance with the prepaid healthcare.
Exactly. New plans as well as updated plans.
Okay. And then, given our marketplace, do most insurance companies like have a regular kind of schedule in which they go about updating plans so that it becomes like a regular update that occurs by the council?
Yes. And so the plans that are reviewed this year, so plans that are reviewed in 2024 are for 2025.
Okay.
And so we need to have early approval on that. So right now, we are looking at 2025 plans.
Okay. And then going to the next slide, I really appreciate this slide about the current state of our deductibles. You know, it's easy enough to say what it is, but can you comment on how this contrasts with plans that we see on the mainland, and how this is really kind of a stunning slide for the state of Hawaii?
Yes. So Hawaii has very low maximums. And if we look at, and I'll talk about a little bit later, high deductible plans, those plans maximums are quite high for out-of-pocket and for deductibles. And so that's where our advisory council will take a look at, and we have looked at high deductible plans previously. In fact, in 2016, there was the review of a submitted high deductible health care plan. And it's something that the state had, although it was approved initially, when it was looked upon as the impacts to the industry for Hawaii and the cost that it would incur for our residents, it was revoked. The approval was revoked.
Okay, so this really is this kind of review process, and these maximums and deductibles really are kind of the places where we can see the guardrails to ensure that health insurance remains affordable in the state.
And that is the goal, is to keep healthcare affordable here in Hawaii.
Okay, if you could just move the thing just a little closer, just, there we go.
Is that better?
Yes.
Thank you.
Okay, I'm done with those questions, so go ahead, continue.
Okay, so then we'll go on to the next slide. So I'm on slide 5. And so the advisory council also reviews health benefits. Prepaid requires health plans to offer a minimum benefits that include hospital, surgical, medical office visits, diagnostics, and maternity coverage that fall within the categories that are listed on slide 5 under these 7 health benefits. So the types and levels of benefits as well as exclusions that are proposed on the plans are reviewed. Noting that plans may qualify for approval if it provides benefits equal to or what we call medically reasonably substitutable for the benefits provided by the plan. And that statutorily, that allowance is there. Going on to the next slide. As with prepaid, the Employee Retirement Income Security Act, which we call ERISA, was also enacted in 1974. ERISA is a comprehensive federal law that regulates the administration of employee benefits, which also includes health insurance plans. ERISA was enacted after Hawaii's prepaid law. So Congress exempted Hawaii from the ERISA law contingent upon no substantial changes to the prepaid law, or we would be in jeopardy of losing our exemption. So our exemption really prevents us from imposing new benefits on employers. Next slide, please. Later, in 2010, was the Affordable Care Act. The Affordable Care Act establishes 10 essential health benefits. Now, the first 7 is, if we go back on our slide, I don't need to go back on the slide, but that was what we are covered in those categories under prepaid. So there's 10 essential benefits, and the top 7 categories are found in prepaid. So next slide, please. Hawaii's prepaid law provides a richer benefit than ACA. And there's more modest employee contributions with prepaid, small employer rating protection, and prepaid requires that all carriers, or that carriers cannot refuse any insurer from obtaining health insurance. Next slide, please. So the effects of the 3 laws and the impacts to Hawaii workers. If we lose the ERISA exemption, the LIR feels it would be detrimental to Hawaii's workers. Employers will no longer be mandated to provide health care coverage to eligible Hawaii workers. Under ACA, only businesses with employees of 50 or more are required to provide health care coverage. Here in Hawaii, an employer has to provide coverage for the first employee, so 1 employee only, as well as Hawaii's workers would be required to work longer hours to be eligible for health care. Prepaid has a requirement of 20 hours, and ACA is 30 hours. It becomes more costly to the employees because the premium contributions will be increased by 8%. Right now, it's capped at 1.5%. With ACA, it's 9.5%, as well as what we'll call an actuarial value, which is the equivalency. Right now, the ACA plans are at a lower equivalency or actuarial value of, it can go down to 60%. With our prevalent plan, we look at it at being at 90%. Next slide, please. Because of the rich benefits of prepaid, in 2016, Hawaii sought after the state innovation waiver, which is a waiver for SHOP, which is the Small Business Health Options Program, for certain provisions. And in December 2016, the Department of Health and Human Services and the U.S. Department of Treasury approved Hawaii's application for the waiver. So ACA SHOP is not required in Hawaii, but what Hawaii's residents do profit from is for the SHOP, there's a tax credit, which actually is replaced by, Hawaii has a premium supplementation trust fund. And so in essence, the Department of Treasury has provided us funding based on the amount that the small businesses tax credit would have been, and it's provided through that fund. So on the next slide.
Before we move to the next
Yes.
slide, I think, we need a little bit further explanation of what SHOP is.
Okay.
And so what does this waiver do? Because really, this is about a segment of the insurance marketplace affecting a segment of employers. If you could explain a little bit about what that is.
I might need your help on that.
And if you can introduce yourself, I know we might be jumping because there's subject matter experts in other areas, but Mr. Ito, if you could introduce yourself.
Oh, good morning, Chair Baladi. Thank you for the invitation to be here today. My name is Gordon Ito. I'm the Insurance Commissioner for the state of Hawaii. And I'm glad that Joanne is here. I mean, we've worked many years together since really 2010 when ACA was passed. And part of the challenge when ACA was passed was to blend the ACA provisions with the Prepaid Healthcare Act. So in regards to the question regarding SHOP, so originally ACA had the individual marketplace as well as intended to have a SHOP, an online marketplace on healthcare.gov. SHOP is intended to be for the small businesses to be able to go on to on the marketplace. You could also buy equivalent plans, what we call qualified health plans, on exchange or off exchange. However, as we were implementing ACA and the full effect was going to start in 2014, there was the decision to not put on a marketplace, electronic marketplace shop. So shop, again, was meant to be for the small businesses. Within the shop provision to encourage, under ACA, small businesses to purchase plans for their employees, as they were going to be required. There were tax credits that were also going to be offered to the small businesses. But because the shop wasn't fully implemented, the states were given an option to seek a waiver, not necessarily with respect to shop, but what Hawaii decided to do in applying for a waiver was to, instead of applying the ACA small business tax credits, we in turn applied for a waiver to get what we would have gotten through the ACA marketplace for a shop, and that those monies we put it into the prepaid healthcare law and the tax credit that was provided within our existing law. So that's kind of, in a nutshell, what happened and what the waiver is.
Okay, and so I really want to focus on this. Is Hawaii the only state that has the shop waiver?
Specifically for shop, is my understanding. Other states have a waiver, the 1332 waivers, but it's on different types of programs, like reinsurance programs. It varies from state to state.
Okay, and then again, I think I really want to make sure that we understand this, that in part, the waiver is because of our unique marketplace. And if you could explain what is a small business, what is the definition of a small business in ACA? That makes this kind of a unique feature for Hawaii.
Yeah. So, well, the definition for small businesses in Hawaii, as well as, the state we're given option is 50 employees or less. Over 50 employees is considered a large group employer.
Okay. And so, again, we received the waiver, and the effect of receiving the tax credits and placement into the supplementation program, what does that mean? How does that play out? And maybe that goes to your next slides.
The next
Yes.
Yes. So if we look at slide 11, so where the Department of Treasury had made that assessment, and they assessed that $2.7 million in tax credits would have been given to the small employers. And so in federal grants was awarded to DLIR starting in October of 2017. And it's available for small employers. They receive a partial reimbursement of the premiums that were paid for their employees. And the waiver extends through 2026. Now with that, I know that we've been asked before is, will we ask for a continuation of the waiver? Because of the benefits to our small employers, that is something that, yes, we would be looking at extending our waiver. So we start that conversations with CMS starting, well, we already have that preliminary conversations, but we do official conversations in 2025.
Okay. And then just so for understanding and grounding this in understanding, this $2.7 million comes from the federal government and is it dependent upon congressional action to continue to fund this and to fund provisions of the Affordable Care Act?
Yes.
Okay. Is there any sense that this is threatened by any kind of legislation pending in Congress, or is that something that we would have to just continue to monitor?
We don't know of any.
Yeah, not specific.
Yeah, nothing specific to this.
And then, again, just kind of a basic question. When you, approximately how many small employers have benefited from this, from being able to receive this partial reimbursement?
I knew this answer, and now I'm forgetting. Several hundred over the years.
Okay.
Sorry, I don't have the exact number.
Okay, we can follow up with that question later. And go ahead.
So go on to slide 12. To summarize, with prepaid, Hawaii's workforce has enjoyed progressive health coverage for the last 50 years, and prepaid provides Hawaii employees with sound health care benefits and financial protection. And we were the forerunner of the ACA. As such, DLIR pays close attention to bills that come forward to the legislators that may jeopardize Hawaii's prepaid law and our ERISA exemption to ensure that Hawaii's residents are being provided sound health care benefits and financial protection by limiting deductibles and out-of-pocket maximums. On the next slide is one of the issues that we see that keeps on returning to legislative sessions. And we just wanted to address some of the areas that are key for us that tie into prepaid. So a high deductible health care plan, kind of talking to answer your question earlier, starts with a minimum deductible of $1,300. That's where it starts at, or $2,600 for the family, which is significantly more than the 0 or 100 from our prevalent plans. So higher deductibles, of course, we feel will place a heavy financial burden on our employees, our residents of Hawaii. The next slide, please. So Hawaii's prepaid requires an employer to offer only one health care plan. DLIR cannot require the employer to offer more than one plan, and it limits our out-of-pocket maximum. So the comparison chart that I have here, I hope will provide some insight as to where our prevalent plans for HMSA and Kaiser are today, comparison to a high deductible plan as well as an ACA plan. So as you can see, Hawaii really has low out-of-pocket maximums, and both for the individual and for the family. So the high deductible health care plan out-of-pocket maximums do not comport with the current prevalent plan maximums.
Okay, I just want to understand this a little bit better. So introduction of a high deductible health care plan jeopardizes cost and affordability, because then individuals have a catastrophic event, they would be on the hook for $7,000.
Yes.
And so for many of our families, in addition to the high cost of living, then the implications, not just a suggestion, is that would be very burdensome.
Very burdensome.
Okay.
So, we hear that high deductible plans are favorable for companies because the premium costs are lower. And so on my next slide, I'll kind of go into where our concerns come.
Okay, go ahead.
Because you have, as you can see, you really have to come out with more money for a high deductible plan. But if a high deductible plan becomes the higher or the prevalent plan, so more subscribers subscribe for a high deductible plan, the current prevalent plans, the HMSA and the Kaiser plans, would erode, which has an adverse impact, financial impact on the employees. Employers are only, statutorily, employers are only responsible for the cost of the least expensive plan. And so if a Hawaii worker did not want to have a high deductible plan, they are responsible for the cost differential between that lower plan and the higher plan.
Okay, let me put a pause on this and just to really understand it. When you say in this slide, employers are only responsible for the cost of the least expensive plan, that's a mandate in the Prepaid Healthcare Act. Okay.
Yes. And so I talked about earlier of us having, they're only responsible, the employee is only responsible for 1.5% of their premiums. They would have to pay the 1.5% plus that difference. So it'd be more than the 1.5%. So for these reasons and others, DLIR is concerned.
Okay, so for the vast majority of employees then, a high deductible healthcare plan is not beneficial.
It's not beneficial.
So I want to play devil's advocate a little bit,
Yes.
because, I have constituents who would be interested in a high deductible healthcare plan. perhaps what is the potential benefit from a high deductible healthcare plan? Or maybe what is the profile of the worker who might benefit from a high deductible healthcare plan?
So it would be someone that is at a higher income level that would be able to afford the high deductibles. But even with that said, it depends on the type of services that are going to be offered. Under the high deductible plans, they also have a health savings account. And so a health savings account through prepaid, we cannot regulate the health savings account. So the employer will put money into the health savings account, and even if you are maybe a medium income earner, you may think that you have this health savings account, but that money can be used for other non-medical services. And so is that money always there? So I think where we would worry is that savings account really going to be there when it's needed? But
Okay.
for the person that's a higher income that could afford it more, I think it may be beneficial for them, but for the department, we have to look at it overall, because then we would be concerned that it becomes the prevalent plan.
Okay, and maybe we need to circle back to this, because I think this is really important about the prevalent plan and how many bodies are covered in this marketplace, because I think this is important to note that, there's a certain profile, of course, that would benefit, or, we have a diversity of products benefit others, but what does our marketplace look like? And maybe that's a question for Insurance Commissioner Ito or maybe Ms. Ige. I'm sorry, I'm popping this off on you folks, but do you understand where the thrust of my question is? I really want to understand the bodies, the people and the workers that are affected by these plans, and what is the potential impact should the prevalent plan be changed because of something like a high deductible health care plan coming into the marketplace?
We have some figures for the small group marketplace. Thank you very much. So we do address some of the marketplace numbers
Okay.
in our slides. And these are figures that are taken from our Department of Labor's shop waiver.
Oh, am I jumping ahead?
Oh,
Am I jumping ahead in this?
We do have some numbers that are dividing up the marketplace by the individual and small group lives.
Okay, why don't we do this, since that's in your presentation? Let's wrap up on this, but if we can kind of hold that question and make sure that we answer it at some point during this briefing. Go ahead, Ms. Vindenar, let's wrap you up, because I think I'm jumping ahead.
I think that I'm kind of at the end of that, but if I could address that just a little bit. I
Okay.
know that we have at least over or close to 100,000 on each prevalent plan that is offered to our subscribers. And I can't give a breakdown of that, but I can just tell you generally that's
Okay,
where we're at. So that is a large portion of Hawaii's residents that would have to, their plans would be impacted.
so over 200,000, about 100,000 on each of the prevalent plans, and those being HMSA and Kaiser. So really, we're looking at a pretty substantial number. Okay, all right, let's move to, I guess, the next presentation, since I'm a little bit jumping ahead. And I'll turn it over to you folks, yeah.
So we'll talk a little bit more in detail in terms of the essential health benefits that Joanne had earlier talked about with respect to what is in prepaid and what is not. So we have an agenda on slide 2, but I'll really start on slide 3 on the EHB. Okay, so the Affordable Care Act, also known as ACA, requires all non-grandfathered and grandmother plan offered in the small group and individual market to cover all what we call essential health benefits, also referred to as EHB. And it was a requirement to start having those EHBs from January 1st, 2014. The ACA defines EHB to include the following 10 benefits, as Joanne had talked about. The three, as you had
Next slide.
mentioned.
Sorry. There we go.
Sorry, that's slide 4. So the three that is not covered or currently under the prepaid healthcare prevalent plan standards is prescription drug, habilitative services, and pediatric service, and including oral and vision care. So these EHBs are offered in the individual marketplace and somewhat the small group plan or the large group plan. So, slide 5. The EHB benchmark plan, the U.S. Department of Health and Human Services, allows each state the flexibility to designate a benchmark plan to serve as the state EHB. EHBs are the package of covered benefits to which insurers apply cost-sharing requirements, resulting in the level of coverage by metal levels and actual value. So a platinum plan, is referred to a 90-10 plan, or gold would be at 80, silver would be 70, and bronze would be 60. And so that's really, I'll stop here a little bit and talk about ACA. So these metal levels, what we refer to as metal levels, are what is on the individual marketplace. If an individual is interested in purchasing a health plan from ACA, the healthcare.gov, you could buy these metal level plans. And so when ACA was passed, again, back in 2010, part of the concern was how do we blend ACA shop requirements with prepaid? Because if you go strictly with the metal levels under ACA, in reality, Hawaii's prepaid prevalent plans are really at a 90-10 platinum level. There might be some plans that are 80-20, but definitely there's those are the prevalent plans. And so with the shop in particular, when we started implementing or trying to implement ACA in conjunction with prepaid, the concern was to make sure that our prevalent plan standards at 90-10 would be maintained, because it's really benefit rich, as opposed to potentially our prevalent plan dropping down to a 60-40 benefit level. Because again, under prepaid, it's the most purchased plan that defines what is a prevalent plan. So going to page 6, slide 6. So let me just talk about really, we've been very fortunate in Hawaii with respect to having ACA as well as maintaining our prepaid healthcare plans. Because on just looking at the individual and small group enrollment, for 2022, the small group enrollment was about 105,000 lives. The average premiums was about $508. In the individual marketplace, which I really believe helped Hawaii actually reduce our uninsured population for healthcare insurance, the 2023 numbers for the individual marketplace, for consumers with an individual plan, 21,645 people in Hawaii had selected and purchased a plan. Consumers, the average premium was $655 for the individual marketplace plans purchased in Hawaii. However, what should be notable is consumers receiving what we call advanced premium tax credits, depending on your level of income. If you're within 100 to 400% poverty level, you would be entitled to get some advanced premium tax credit, which would reduce your out-of-pocket costs for your healthcare premiums. In 2021, they actually raised it above 400% federal poverty level for individuals entitled to some premium subsidy, and that's going to continue to 2025. What's really important is, consumers in Hawaii, 17,817 of that received the advanced premium tax credit, so quite a sizable amount. And the average premium after the premium tax credit that consumers that paid out of pocket really was, the premium tax credit was on average about $140. So the consumers with premium, and there were also consumers with premiums that purchased from the individual marketplace that their premiums was less than $10 a month
Wow, that's
after the premium
that's
tax credit.
incredible.
Right, and so that's really on the individual marketplace side, it's been very beneficial for Hawaii,
Can I ask a couple questions here? Just because I do think that this is an important slide. So this slide actually illustrates how we have successfully integrated prepaid healthcare with ACA to create an affordable insurance product for over 20,000, for many in our state.
Yeah, so, we also have to be mindful because when we talk about individuals, many of the individuals are those that do not qualify for plans under prepaid. They work less than 20 hours a week. So it provided those individuals who work part-time and did not qualify for really prepaid employee-based coverage to be able to buy insurance from the individual marketplace. And also, more importantly, if they're within that 100 to 400% federal poverty level, would be entitled to get tax credit. There's also the option in terms of depends on your where your income is. The option in terms of perhaps getting coverage through MedQuest. And in Hawaii, the way it's set up is you can go to the system and there's no wrong door. So depending on your information, you could potentially be referred to MedQuest for possibly coverage. So just in terms of, I don't have the exact numbers right now in terms of the marketplace, but I believe there's about 600,000 to 700,000 covered lives that are in a large group marketplace. The small group marketplace is current,
The 105,000
105,000.
in this 2022.
Yeah, and then I believe with MedQuest, there's somewhere between 300 to 400,000 covered lives right now. And so that's kind of generally how the marketplace is structured in Hawaii. I apologize for not having the exact numbers.
Maybe if we could get this information, because I think this is really important to understand how many lives are covered in the large marketplace. You said the small marketplace, and then covered lives within Medicaid, because then that gives us the aggregate number of insurance covered lives in the state.
And there is a small, unfortunately, population of uninsured.
Okay, can I go back to this question of what is happening in the marketplace, the individual marketplace? Are the individuals who are purchasing, what plans do they gravitate towards? Platinum, gold, silver, or bronze?
When the ACA first started, we did see folks migrating towards the platinum plans, the richer plans. However, the benefits to get your subsidies are really based on your silver plan. You can get those subsidies and actually purchase up or down as well. But I believe now we're seeing more so individuals in the silver plan. There are charts publicly available out there that break it down, and we can get very good granular data for that marketplace and also report that back to you.
I think that would be interesting to know because, and this I guess was not clear. So subsidies, the APTC that we have over 17,000 Hawaii folks drawing down on is really only received if they purchase the silver plans. So there's going to be a migration. No, go ahead.
It could be, it really depends on your income level and the metal level. So it's not only limited to silver plans. But I believe the item that we say that there are some consumers that have pay premiums less than $10 a month. I think most of them are in the silver plan.
Okay. But the activity that goes on in this marketplace is not eroding the prevalent plan at this point in time.
Yeah,
So really, for the marketplace as a whole, we're really preserving a very rich benefit plan for the entire marketplace and for the benefit of more individuals.
Yes.
Okay.
You know, as I noted, I think our uninsured population as a result of ACA went from somewhere about, I think, 6% to I think we're somewhere down in the 4% now.
Would you have the data to show how many individuals might be up purchasing, so they stay at the silver level and then they go ahead and purchase more?
I'm not sure if that's available, but I believe we can get the breakdown by meta level.
Okay. And again, this is a mechanism or that allows consumer choice.
Yes.
Right? Okay. Okay. And again, just to emphasize the point, this set of the marketplace really captures the gap group that prepaid healthcare left uninsured. And it's that folks who are part-time employed.
For the most part, yeah, that's correct.
Okay. Okay. I learn something new every day. So that's actually a very important point. So this, again, ACA is good for Hawaii because it closed that gap.
Yeah, I mean, again, we lowered our uninsured population for health insurance from around 6%, 7% down to somewhere about 4 to 5% that we.
Okay. Okay. Thank you. Sorry I've interrupted. Go ahead.
And so I'll turn over the next few slides in terms of the EHB benchmark plan and what may happen in the future.
So we're on
Arlene.
slide 7.
And before she starts, you know, Arlene Ige is our health insurance branch administrator, and Ian Robertson is our general counsel at the insurance division.
Okay, so the ACA does address additional required benefits in an EHB benchmark plan. A state may require a qualified health plan to offer benefits in addition to the EHB. A benefit required by state action taking place on or before December 31st, 2011 is considered an EHB. A benefit required by state action taking place on or after January 1, 2012, other than for purposes of compliance with federal requirements, is considered in addition to the essential health benefits. So slide 8. Presently, states may select a new EHB benchmark plan for plan years beginning on or after January 1, 2020 from the following options. So there are 3 options. Option 1, selecting the EHB benchmark plan that another state used for the 2017 plan year. Option 2 is replacing one or more categories of EHB with the same category or categories of EHB from the EHB benchmark plan that another state used for the 2017 plan year. And option 3 is selecting a set of benefits to become the state's EHB benchmark plan. Slide 9. So to change an EHB benchmark plan, states are required to, 1, notify the Department of Health and Human Services on the selection of a new EHB benchmark plan by a date determined by HHS for each plan year. So that's generally in May. 2, submit documents as specified by HHS. And 3, provide public notice and opportunity for public comment. And the 4th step is to submit a new EHB benchmark plan compliant with HHS requirements. On slide 10, CMS issued the plan year 2025 Notice of Benefit and Payment Parameters for rules effective in 2025. CMS proposes updates on state requirements to revise their EHB benchmark plan for plan years beginning on or after January 1, 2027. CMS proposes to remove the prohibition on routine non-pediatric dental services as an EHB, which would remove regulatory barriers to expanding adult dental benefits. And third, CMS proposes revising the section so that state-mandated benefits would no longer be considered in addition to EHB under the CMS defrayal policy if the mandated benefit is an EHB in the state's EHB benchmark plan.
Okay, can I put a pause here, just because I want to make sure that before we move on further, can we go back to the sections on page 7 slide 8, excuse me. So I just want to kind of make the point that our EHB benchmark plan was what did we decide as a state for our EHB plan when ACA was implemented?
Would you like to go over that? Okay. So we did conduct an analysis, and back in that time when we were able to select our plan, the options were different. So we could select from several options, including, the largest of the small group plans in the state, your federal plan, and other options. We conducted the analysis, and in discussion with stakeholders, it was decided that we would select the benchmark plan that was most closest to the Department of Labor's Prepaid Healthcare Act's prevalent plan, so that it would be least disruptive to the state. So that continues to be our benchmark plan today. It was a plan that is most consistent and close in terms of benefits to the prevalent plan with the Department of Labor.
At the time in 2017.
It was a bit earlier. It was about in 2012, 2013, when the marketplaces first opened up in 2014.
Okay, so then looking at slide 8, we have never initiated this process.
We have not done these three options.
Okay, have other states engaged in this process to change their EHB benchmark plan?
Yes, there have been some other states. It might be between 10 to 15 states or so that have done some updates to their EHB benchmark plan.
Okay, so in the context of some of the legislation that we see, and that we've seen consistently since the implementation of ACA for new mandated benefits, is this kind of the process that was underway from 2020 to now that would have allowed for a state to most correctly change its essential health benefits under the ACA?
So these were the three options that were available, and so this would be the process that was described after 2020 on how you can update your benchmark plan.
Okay. This is a little bit more of a policy question, but is there any reason why we would want to look at another state's EHB plan to see if that might be something that we wanted to adopt? Or given our unique situation with prepaid healthcare, that's never even a consideration by either the insurance division or anyone who's really looking closely at health insurance benefits in the state? And maybe that's for Commissioner, because it's more of a policy question.
So to answer your question, I mean, I think we should look at and go through this process, whether it's for 2025 or 2026, to not so much look at other state EHB plans, but in terms of our plans and what is offered in the prepaid, because there may be additional benefits that have been added that is not in the current the plan that we had selected back in 2012 or 2013. And so it is an opportunity to review that process and see if we should update our EHB plan.
Okay. So with that in mind, then when we go to slide 10, which you had started to go into, Ms. Ige, right? So this new proposed EHB policy changes is a new process that CMS is initiating. Is my understanding correct?
So these are proposed rules effective in 2025, and it's effective in 2027. And these are some of the updates of how a state can update their benchmark plan. And so some of it also includes allowing for non-pediatric dental services, and then also proposing that state-mandated benefits would no longer be considered in addition to HB under the defrayal policy if the mandated benefit is an HB in the state's HB benchmark plan. So those are new proposed rules. They have not been finalized at this time.
When is CMS projecting that these might be finalized, or is that something we have some kind of view on?
It's hopeful that we may see a finalized version in the next few months because these are rules that will go into effect in 2025. So the plans submitting or their filings for this year would submit and file in 2024 for that review and approval process.
Okay. Because this is really important, and I don't think you have any other slides on this, can you explain more, maybe Commissioner Ito, the defrayal policy, and why is this new proposal or this new way of, picking a new EHB benchmark plan important? with regards to defrayal.
So let's just start on, keep it on slide 10.
Okay.
Right, and in the second paragraph where you talk about the EHB and non-pediatric dental. So going back in time when the EHB lists, I mean, if you notice that pediatric oral dental and vision is a EHB, but for adults, if the state were to add adult oral and vision coverages, oral and vision coverages, that would be outside of the EHB, and the state, if it added that benefit, would be subject to what they refer to as defrayal. The state would have to pay for the cost of the new benefits that were not in place at the time we made the selection, the benchmark plan selection. And so just on this item, there's a potential to add on, say, adult dental and vision in 2027. And if at that time the plan adds that benefit, the defrayal issue would go away. Right? And so that's where the state would no longer, if we added that adult oral and vision benefit, it wouldn't be subject to defrayal.
Okay,
Where
so,
the state would have to come up with the money to pay for that benefit.
okay. Can I just put this in kind of terms with slide 6? So currently, the folks who are purchasing ACA plans in the individual marketplace in the amount of 20,000 people do not have adult dental benefits covered because that's not an EHB within their plans.
That's correct.
But with this coming change that we could anticipate, that is going to be a benefit if we decide, if this CMS rule goes through.
And that benefit is added into the benchmark plan.
So we would then need to take, so once CMS takes action and say this rule does go into effect, then we would need to take action and you guys would initiate the process of trying to introduce a new EHB plan for our marketplace that would include adult dental.
Yeah, because if the benefit's not, I believe, is not added into the plan, and you adopt a plan that doesn't have that benefit, then you're still potentially subject to the defrayal issue, because it's not part of the new EHB plan that's selected.
So knowing that this is on the horizon, are insurance plans now looking at potentially crafting a plan that would have adult dental benefits?
I can't answer if they're looking at that, but I'm sure they're aware of, this upcoming potential change.
Okay. So that's a really specific kind of like potential expansion of EHBs. But in the prepaid healthcare plans, there are no dental benefits as a required benefit, correct? So what is the implication if we were to now have a plan that had a benefit that prepaid does not have? If you know what I'm saying?
That's where we would look at, is it in an additional benefit? And because it is currently covered for pediatrics on the prevalent plan, we'd need to look at assessing if that really is considered a new addition, which I don't have that answer for you, but I'm not as concerned with that one as, because it's already dental services.
Okay. Let me go in another direction. So, Commissioner, on this third point on slide 10, is there concerns that current legislation moving forward that has proposed additional benefits are in addition to HB? So is there do we have to be concerned about defrayal when we're looking at adding insurance benefits to the insurance code?
Yeah, currently, I mean, if there are added benefits that is not currently within the EHB plans, then the defrayal issue arises.
Okay,
Until there's an amendment to what benefits are within the EHB, then any new benefits that's added that's not in the current EHB plan would be subject to defrayal.
okay. How many states has there been any defrayal actions raised against any states? And then how have other states responded to this defrayal question?
So I think there's been some, maybe 2 states that have taken on the issue as to the exact parameters and what they have done. We can't comment specifically on.
Okay, okay. All right, go ahead with the rest of your slides, I'm sorry.
Okay, thank you.
We're at 11, I believe.
Yes, slide 11. So if the plan year 2025 notice of benefit payment parameters is finalized, states may be interested in updating the EHB benchmark plan applications in May of 2025 for an EHB benchmark plan effective in plan year 2027.
Okay.
And then our final slide is a thank you and to come and visit us on our website.
Okay, before we go on to the next, and I think we're almost at the end of it, and we're making good time because it's about an hour. We saved the hardest for the last, but before we move on, so would it be the recommendation of sort of the Insurance Division and Department of Labor that we pause on kind of benefit changes, look to engaging potentially in the EHB policy changes that CMS appears to be encouraging states to undertake as a way forward for the entire insurance marketplace? If you can give any recommendations, Commissioner Ito.
I would not, I can't give a recommendation because, it's really a public policy call for the legislature. But, thank you for this briefing because it hopefully raises awareness that this is a possibility that's available down the road. And so it's really taking that into consideration what you do with some of the bills that are pending or may be pending even or introduced next year, before there is or potential is an adjustment on the EHB.
Okay, thank you. And I believe the last item on our agenda is sort of the potential impacts of ACA litigation. So we know, thankfully, we know that the Prepaid Healthcare Act has not been challenged, but we know that the Affordable Care Act is kind of a hot potato at the national level. So the concluding part of this briefing was to really kind of look at the potential impacts of ACA litigation on the design, benefits, and coverage of health insurance in Hawaii. So I'm going to turn it over to the AG's office. And I know, Brian, you and Lauren have something to present.
Lauren will be able to.
Okay.
It's better than I could.
And thank you, Ms. Chen, for joining us.
Yeah, thank you very much, Chair. So I think you were specifically interested in the Hobby Lobby case and the Braidwood versus Becerra case. So Hobby Lobby was, of course, a U.S. Supreme Court case, and that struck down the contraceptive mandate under the ACA. The Braidwood case, it was only a Northern District of Texas case, so still a trial court case, and it's currently on appeal in the Fifth Circuit. But what the trial court did was to strike down another mandate of the ACA, which was the pre-exposure prophylaxis mandate or the PrEP mandate. And what both of these cases did is say that those mandates violated a specific federal law called the Religious Freedom Restoration Act. What they did not do was strike down either of those mandates based on a First Amendment religious freedom type of claim. So importantly for us, that federal statute, RFRA, does not apply to the states. It only applies to the federal government. And there's no state equivalent to RFRA in Hawaii. So we're bound by the U.S. First Amendment and our Hawaii Constitution. But because neither of those cases struck down either of those mandates based on the federal Constitution, they shouldn't have an impact on any of our existing mandates in Hawaii state law.
Braidwood has been raised in a number of bills moving through the legislature. So understanding that it's only in the stage of a district court, what could be the anticipated movement? Because any, like, Hobby Lobby ended up ultimately at the Supreme Court. What is the timeline for Braidwood perhaps having any effect?
I'm not sure. It cannot be heard by the Supreme Court this year. I mean, it's still, no decision has come out from the Fifth Circuit yet, so I think it would be at least a year or two,
Okay.
but that's speculative.
Okay, are there any other areas of litigation that we need to be concerned with ACA and how it might impact us?
Yeah, I don't think we're aware of anything right now. We can follow up if you have
Okay.
specific questions.
Okay, so, yeah, you know, in this area of healthcare services, which has become highly political in so many ways, I think it's important that the legislature be kept apprised of how these might impact. I mean, we can respond quickly when detrimental decisions come down from the federal Supreme Court, from the Supreme Court of the United States, but we just need to be made aware of those. So I really appreciate the quick briefing on Braidwood and its potential impact on us, and so we'll just be watching that. Does Braidwood also just raise, does Braidwood raise any challenges based on the federal Constitution as it's moving now?
I don't believe so, because the Fifth Circuit specifically didn't reach that question because they struck it down on RFRA. They didn't need to go to the First Amendment.
Okay.
I guess it's possible that an appellate court might want to reach it anyway, but again, that's
Something we should just monitor?
right.
Okay, understood. All right, thank you. I guess that was not, it's good when litigation briefings are shorter than anything. I'd like to just offer any closing remarks. I don't have any questions because I think all of my questions were asked along the way. So I'll leave it, let's start with Lauren. Or Ms. Chun, Mr. Yi, any comments? No,
Nothing.
Thank you.
okay. Commissioner Ito, your staff?
Just, again, really thank you, Chair Baladi, for this opportunity to brief you and the committee. This is a very important matter, as you had mentioned. We should be celebrating the ACB Prepaid 50th anniversary because it has really been beneficial for really everyone in Hawaii. I think we're often ranked number 1 or 2 as the healthiest state, and a large part of it is due to prepaid. We are also fortunate to have ACA that has actually really complemented our prepaid healthcare law by offering the individual marketplace and individuals to purchase healthcare coverage through healthcare.gov.
Thank you. And Ms. Wed Mar, since you deal mostly with all of our prepaid healthcare plans and making sure that those remain in place and that our law is followed with fidelity, closing remarks for you.
Oh, I just appreciate this opportunity because as Commissioner Ito has said, and we thank you for bringing this important matter forward because preserving Hawaii's healthcare should be our priority. And so having prepaid intact allows for that. And so we thank you.
Thank you. I'll make one closing remark. I think, cost of living is a high challenge for so many residents in the state. And sometimes we forget that it's because of the Prepaid Healthcare Act that at the very least, our healthcare costs are somewhat kept affordable because of that. And it was because of the legislators of 1974 who really fought for that groundbreaking law before the nation was even acting upon it. And then we were able to secure an ERISA exemption to preserve that. So I really appreciate the time and the effort that was taken. This is going to be shared with my colleagues, and for the public. The presentations will be posted, as I think it provides very good information and details as we move forward in conversations about healthcare and healthcare reform. On that note, it is now 11:05, and we are adjourned.